Mm. There we go. I hope you can all hear me well. Yeah, so welcome and thank you, all of you, for joining today's webinar. My name is Dr. Sofia Wenzler. I'm a licensed clinical psychologist and the clinical lead here at SkinPick. SkinPick is a therapist-assisted online program that helps people learn to cope with their skin picking and is basically bringing this webinar to you. Today, we're going to talk about automatic versus focused picking. My presentation is going to be about 40 minutes long, and then at the end, we're going to have a Q&A session where you can ask any question that might have come up during the webinar. You can write this question down in the Q&A section during the webinar or after, and I'm going to get to as many of those as I can. Please don't raise your hand, just write the questions down, even if it's a follow-up question. And also, I want to encourage you to stick around until the end, because if you do want to join SkinPick, then we're going to have a promo code for you for your first subscription. All right. Yeah, so I have to say, when I was preparing for automatic versus focused picking, I thought this was going to be a more theoretical webinar on skin picking basics, and I was very surprised. It turned out much more interesting and raised much more questions than I had thought. And I'm really happy to discuss those with you as well. We're gonna, where are my slides? Right here. This question, automatic versus focused picking, basically brought me back to the question of what is a BFRB. I don't know why I wrote BFRB here, body focused repetitive behavior / what is skin picking actually, what is it related to in terms of like, how can we categorize it in the broader group of psychological conditions? When we ask what is skin picking actually, what can we learn from the brain, from from neurology, and the question of whether there are different subgroups of skin picking with which we can actually categorize different kinds of people who suffer from skin picking, and what does that all mean for treatment? And those are all the questions that we're going to deal with today. So let's start with what is a BFRB, or again, what is skin picking disorder? So it's, as you all know, highly stigmatized. There are a lot of people don't know what it is, and even professionals that should know what it is sometimes don't know how to treat it. I mean, that's one of the reasons why we kind of designed this program, SkinPick, so professional and specialized treatment would be available wherever you are, right? But like, one of the basic questions when we ask what is skin picking is whether it is compulsive or impulsive in nature. And to demonstrate what I mean by that, I have a few case examples for you. First case example. In the evening, Emma is sitting in the living room watching a TV show after coming home from a long day at work. Her hand absentmindedly wanders to her arm, where she has a few small bumps. As she focuses on the show, she starts rubbing and picking at the area, completely unaware of her actions. By the time the episode ends, she looks down and notices her skin is red, raw, and slightly bleeding. So if you ask yourself again, is skin picking more impulsive or compulsive? What would you say in that example? Is it an impulsive or compulsive action? So in this case, we're talking about automatic unconscious picking, which we would say is more impulsive. We follow an impulse without even noticing it. Whereas in the second case example, it's different. Mark is getting ready for bed when he notices a small bump on his cheek in the bathroom mirror. Feeling an overwhelming urge to fix it, he examines his skin under bright lighting. He starts squeezing and scratching at the bump. What starts as a few minutes turns into an extended session. He moves from one spot to another, searching for tiny blemishes, blackheads, or rough patches. He feels a sense of satisfaction while picking, but when he stops, he realizes his face is red and bleeding in several places. So obviously, it's not hard to guess that when the first case example was the one where I aim at like it being more impulsive, then this one is the compulsive one. We also call this focused picking, and that's where we're really conscious. The urge comes up, and sometimes I even know already on the ride home, I'm gonna pick. I already made the decision, and I feel almost compelled to do it, almost compelled by the urge. So that's what we would say is more compulsive, and that's also why we sometimes have a hard time deciding whether skin picking is more of an impulsive or compulsive action, because there's those two kinds, right? And the fact that there are those two kinds of picking are what makes it so hard to categorize. Um, so if we look in order to understand those two kinds of picking on a deeper level, we can basically try to compare them to other kinds of psychological conditions, right? So I have again some case examples for you, because I always think it's easier to stay engaged if I ask questions and you try to um, answer them yourself, um, than when I just present a lot of knowledge. So let's look at the first case example, and I want you to think whether you know what kind of psychological condition that is, and then also think whether you find this more impulsive, more like the impulsive automatic picking, or more like the compulsive focus picking. Alex, a college student, sits in class focused on the presentation of his professor. He repeatedly clears his throat and blinks excessively. His professor asks if he has a cold, but Alex is surprised. He didn't even realize he was doing it. Later, his friends mention that he shrugs his shoulders frequently, something he wasn't aware of while it happened. So again, think about whether you find this case example more representing an impulsive or compulsive behavior, and whether you know what we call this condition. Okay. So this would be an example for another psychological disorder that is more automatic and unconscious and impulsive in nature, and this would be tics, a tic disorder, right? So clearing your throat, blinking, um, shrugging, those are typical tics. And here's the second case example. David has a strong need to ensure that his apartment is secure. Every night before bed, he feels the need to check that the front door is locked. Even though he locks it once, a nagging doubt creeps in. What if I didn't lock it properly? He gets up, walks to the door, and checks it again. This brings temporary relief, but as he returns to bed, the thought resurfaces. He repeats the process over and over. He's fully aware that he is doing this, and part of him recognizes that it's excessive, but he feels powerless to stop because the anxiety is overwhelming. Do you know what that is, that behavior, what we categorize it as, and whether you think it's more impulsive or compulsive? Okay, so this would be an example of OCD, obsessive compulsive disorder. And that is more comparable to the focused, conscious, and compulsive aspects of skin picking. So as we further kind of try to understand those two categories, okay, we see automatic slash unconscious slash impulsive picking is more like tic disorders, can also be compared to ADHD, not the I mean, what we usually think of when we talk about ADHD is troubles concentrating, but what we also often see in ADHD is mindlessly switching from one task to the other, impulsively interrupting someone who is talking without noticing, and unconsciously fidgeting, like tapping your fingers, bouncing your leg, or playing with objects. And that is more comparable to the impulsive automatic parts of skin picking. And then also I thought about binge eating disorder, but then I kind of regretted it because there's also like binge eating can be impulsive and can be compulsive, kind of like similar to skin picking. So I wouldn't put it in unanimously in one of those categories. So I put it in brackets. And so this kind of picking is done suddenly and without thinking, triggered by passive activities and hard to control in the moment. On the other side, we have the focused, conscious, and compulsive picking that is more comparable to, as we saw in the case example, OCD can be compared to body dysmorphic disorder, which behaves a lot like OCD, and generalized anxiety disorder that is categorized by compulsively worrying in a way that it really interferes with life and functioning. So in that case, the behavior is driven by a conscious urge or need. After picking, we feel a brief relief followed by repetition, and it can become really time consuming when we get into this hyper focus and just like go on and on. Another way where we can see this connection to other psychological conditions is by the co-occurrence, or how we call it, comorbidity that skin picking disorder has. So interestingly, there is a big part of people who suffer from skin picking disorder that also suffer from ADHD, about 24%, which would be the compulsive, like kind of represent the impulsive part of it. But on the other hand, and those are just examples, right? Skin picking can co-occur with a lot of different conditions. But on the other side, if we look on the more compulsive aspects, then we see that there's 26% co-occurrence with OCD and 22 to even 63% co-occurrence with generalized anxiety disorder, which I don't like the 63% that study. I didn't look into it deeper. It sounds like a really high number, but the reality is probably somewhere in between 22 to 63%. Yeah, so even if we look at the co-occurrence, we still see, both sides, the impulsive and compulsive part. And as I said, this can confuse even professionals, even those who really are experts for skin picking and other body-focused repetitive behaviors to a degree that if we look at the Diagnostic and Statistical Manual for Mental Disorders, in short, DSM, we see that from the fourth version in 1994, where skin picking slash hair pulling, in this case, in 1994, skin picking wasn't categorized as its own condition yet, but it was basically but it's always in the same category as hair pulling disorder, trichotillomania. So it was basically grouped within the bigger category of impulse control disorders. So we used to categorize or diagnose skin picking disorder as an impulse control disorder not otherwise specified. Right, so within this group, where we also find trichotillomania, which is hair pulling disorder. So it used to be categorized as an impulse control disorder, but then in 2013, when the newer version of the DSM came out, the DSM-5, it was grouped differently in a new group that we didn't have before, that's called obsessive compulsive and related disorders. So then all of a sudden it wasn't in a group anymore with more impulsive disorders such as kleptomania or pathological gambling. Now it's in the same group as OCD, which I mentioned before, body dysmorphic disorder, and hoarding disorder. And now we also see skin picking disorder being categorized as its own diagnosis. So that's the level of confusion. We're not even sure in which group to put skin picking disorder, because there's those two kinds of picking. So that would be on the level of symptoms, what we see on the outside, similarities that we see with symptoms of other disorders. But what happens if we actually look deeper, if we look at brain structures and neurotransmitters? What can we learn from the brain in that case? And if we look at impulsive or compulsive disorders more in general, then we see that there is one group or network of brain areas that is almost always involved. I want to just check, for example, for a second, the questions, because I felt like my internet is unstable. Let me see if someone complained. No. Okay, well, that's good. I hope you guys can hear me well. So all of those behaviors where we have a hard time controlling our actions are related to this brain structure that you might remember if you attended my webinar on connections between OCD and skin picking. It's called the cortico-striatothalamo-cortical circuit. And because I pronounce this very German, I'm going to just call it the CSTC circuit. And yeah, so basically every impulse control or compulsive disorder is somehow related to this brain area. But for all further explanations that I'm going to give now, I'm going to relate to ADHD and OCD, because ADHD is more on the impulsive side and OCD is more on the compulsive side. And we have much more research when it comes to ADHD and OCD than when it comes to the two subgroups of skin picking, automatic and focused. So we're going to use ADHD representing impulsive behaviors and OCD representing compulsive behaviors. Okay. So as I said, this circuit is involved in ADHD as well as OCD, and it basically starts with the cortex. The cortex is like the prefrontal cortex specifically is here where your forehead is. It's the outer layer of the brain. And so you see kind of variations or abnormalities. That's a weird word, but like activity levels that are not seen in people who don't have ADHD or OCD in the prefrontal cortex when you see ADHD or OCD. But the difference is that in ADHD, you have a reduced activity in the prefrontal cortex, whereas in OCD, you have an increased activity in the prefrontal cortex. So we can see the brain, first, the same brain region is involved, but differently. One is hyperactivated and one is hypoactivated, right? There's reduced activity. And what the cortex does in this kind of in the circuit is it's processes information from our senses and formulates thoughts. So it kind of receives the signals from the outside and then does a first processing of them and sends those signals to the striatum. The striatum receives signals from the cortex and helps to determine which actions to take. So it evaluates the information and then decides whether a behavior should be initiated or not. And then when you look at OCD, you can basically understand, okay, in the striatum, we have a problem inhibiting compulsive actions. So in comparison to people who don't have OCD, if we look at people who do have OCD, we will see less inhibition in compulsive actions. For example, if the cortex kind of sees, let's say, the most typical example for OCD, a doorknob, and interprets it as maybe there's germs on this doorknob, then the striatum will kind of make the decision of like, okay, well, maybe we should not touch it, or maybe we should wash our hands after touching it. And the same goes for ADHD. So this, when it comes to ADHD, there's a problem inhibiting impulses or stopping before impulsively acting on a sensory information that the cortex picked up. And then we have the thalamus. That's the last part in the circuit, which is called the brain's relay station. It takes information from the striatum and then sends it back to the cortex for ongoing feedback, right? And this is where we have the problem with OCD, where after I wash my hands once, I don't get the check sign. The thalamus sends back the information to the cortex, and we get into a loop of like, okay, well, maybe the doorknob was contaminated, so I should wash my hands. Or maybe my hands are not really clean now, so maybe I should wash them again. So there's a problem with the feedback loop here. Whereas in ADHD, we also know there are problems with ongoing feedback, because in the end, we have the opposite. We have a problem to stay focused on one task. So we move on too quickly to another task. So again, we have a problem with this feedback of like, no, this task is not ended yet. You should stay with this task, right? But then we move on. So again, it's very different from ADHD. But the same brain structures are involved. And at this point, we could probably say, okay, well, then that makes sense. Okay, we have the same brain structures. There's a lot of commonalities, but there's also differences. Sometimes there's hyperactivation for OCD and hypoactivation for ADHD, for example, in the prefrontal cortex. So it's the same brain regions, but different levels of activations. But then what becomes really confusing is that we have people who have both. We have people who have OCD and ADHD. And then we have to ask ourselves, how can that be? So, for example, if we look at the prefrontal cortex, people have ADHD and ADHD, which is, for example, 12% out of all people with OCD also have ADHD. That's a very significant part. So, is their prefrontal cortex hyper aroused and hypo aroused, which means decreased activation? This seems to be an inherent contradiction that, to be perfectly honest with you, we don't have an answer for yet, but it kind of means that it might be similar for those people, similar to people who suffer from skin picking disorder, where you also have the compulsive and the impulsive aspect as well. So you could almost, but that's like really a far stretch, but say, okay, so maybe skin picking disorder is a little bit like you have a little bit of both. Like you have the compulsive and the impulsive part, almost like someone who has ADHD and OCD. But that sounds really scary because those are two, very serious conditions, just like in nature, right? But obviously, as you see, we're still lacking answers and we still have a lot to learn here. So those are just really far stretched hypotheses at this point. Um, if we think about these two categories, automatic and focused disorder, focused skin picking, another option would be that no, like it's not mixed. There's just two subgroups. Okay, so there's people who are more automatic pickers and they're more impulsive. And then there's people who are more compulsive pickers, focus pickers, and then the behavior is more compulsive. So it's just two groups of people within the big group of people who suffer from skin picking disorder. And that is actually a question that has been examined by research. And what we found is that there really aren't two subgroups. You can't really say this is an automatic picker and this is a focused picker. Most people who suffer from skin picking disorder have both. They know automatic picking and focused picking. And interestingly, even the same picking episode can be both automatic and focused, or can switch from automatic to focused or from focused to automatic. So you really can't use this to categorize subgroups within all people who suffer from skin picking disorder. So you might say, okay, well, why bother, right? Why do we even think about those two categories? Why do we try to understand it through brain functioning, through comparing with other psychological disorders? Well, this question is relevant because it has implications for treatment. It has implications for treatment because we learning to cope with impulsive behavior works differently from learning to cope with impulsive behavior. And before I'm gonna dive into some implications and tips for you in terms of how to deal with automatic and focused picking, I want to ask you, or like discuss with you, a question that came up for me at this point when I was preparing the webinar, because then I thought, okay, so those are two kinds of picking. Most people who have skin picking disorder know both automatic and focused. So is the only difference between the two of them the level of awareness at this point? So automatic picking is like I'm doing it impulsively, I'm not really aware of it. And the moment I kind of raise it to awareness, then it's almost like focus picking. Or are those two very different qualities of picking? And this is not a question where I have a definite answer for, right? So I thought it would be really interesting to just also like put it out, like formulate this question here. And if you have thoughts on that or want to share your own experience, you can write it down in the Q&A section, and I'm gonna go through that later, right? So because there's no real evidence for that question, but I thought it was really interesting, I actually asked that question to our therapists at SkinPick. Our therapists have worked with hundreds of clients. I have a lot of experience and a lot of expertise and knowledge when it comes to skin picking. Because, I mean, if the only difference is the level of awareness, then therapeutically also it's very easy. So you have to raise awareness, not easy, it's never easy, but like that would mean for automatic picking, you just have to raise awareness and then afterwards use the same tools you would use for focus picking, because the only difference is the level of awareness. Um, I found the feedback that I got from our therapist very interesting. I tried to kind of like sum it up for you, and I think one of the most interesting ideas that came up was that automatic picking is it seemed to some of our therapists more like passively avoiding something without noticing it. So for example, if you're subconsciously overwhelmed by something and the picking is then the coping mechanism, but you aren't really aware of this connection and you don't really make the decision to pick, but there's still an unconscious trigger for it. So, for example, let's say there is a task that you subconsciously fear or think that you're not up to, that you might fail at. And then instead of tackling this task, you all of a sudden find yourself scrolling through YouTube, picking absently, right? So you did have a trigger. You're passively avoiding something, but you're kind of avoiding it by drifting off, by automatically picking and not being really present. And this is an automatic mechanism that you don't even notice, or where you really have to stop and reflect and connect some dots in order to notice it. Yeah, so one of our therapists wrote, like, automatic picking means that really you're unaware of what's going on with you in that specific moment or considering that specific situation. It's almost like a lack of presence in the moment or willingness to connect with the moment, because the moment there's something difficult or uncomfortable in this moment. So basically, I would say that I think our therapists' general tendency was to say that even if you take the level of awareness away, there's still two different qualities to focus and automatic picking. But yeah, I'm excited to later on read your ideas on this topic as well. Where, what are the implications or treatment when we try to consider those two subgroups focused on automatic picking. The first thing that came to mind when I was researching for this webinar was that, okay, maybe the fact that there's two kinds of picking that on a neural level also have different qualities and different activation levels in the brain, maybe that explains why we have such heterogeneity, such variation, and no clear direction when it comes to medication. So in comparison, if you look at OCD, the medication direction is very clear. You know, you would use an SSRI in high dosage. On the other hand, if you look at ADHD, also the direction in terms of medication is very clear. You usually use, again, I can't say this with an English accent, methylphenidate, for example, Ritalin, to treat symptoms of ADHD. But then if we look at skin picking, we're kind of all over the place, right? You have NAC, which was identified as basically, first of all, we don't have any candidate where we say this is effective and this is recommended unanimously, right? But we have interesting directions. We have NAC, which was identified as most effective in combination with therapy in a recent meta-analysis. And that one affects glutamate, which is one of the neurotransmitters that is involved in the CST circuit that I presented to you before as well. But then we also have aripiprazole, which would be an antipsychotic medication that balances dopamine levels. So completely different neurotransmitter system. And then another promising medication would be MAOIs, monoamine oxidase inhibitors, which those kind of affect neurotransmitter systems such as serotonin, norepinephrine, and dopamine at the same time. So whereas OCD clearly, where in OCD we clearly use medication that influences serotonin levels. In ADHD, we use medication that influences dopamine levels. But then in skin picking, it can be glutamate, it can be dopamine, it can be serotonin, even norepinephrine. It's much less clear. And that might be due to the fact that there's two different categories of skin picking. Also, this really kind of made me think about the effect that Ritalin has on skin picking, because some people suffer from ADHD and skin picking, as we just saw previously. There is a high level of co-occurrence. And so some people feel that if they take Ritalin, it really increases the urge to pick, and others don't see this effect. So maybe that's also related to the two subgroups. Ritalin has a different effect on automatic picking than it has on focused picking. Maybe another question to ponder. If we think about the elements of treatment that we usually see in the common, most effective treatment options or therapy options for skin picking, then we would say, effective things would be awareness training, understanding our triggers, anticipating and planning for our triggers, changing the environment, and practicing competing response. Right? And generally, if we look at the differences between automatic and focused picking, I still would say each one of them is relevant for kind of both categories, but there might be slight differences. And this is now not based on research, this is based on my experience, on or a therapist's experience, but I think, therapist's experience is still a valid source of information. So for automatic picking, definitely awareness training is super, super important. The whole point is that picking happens automatically and subconsciously or unaware. So awareness training, logging, picking episodes, even if you log afterwards or just notice in the middle, is very important. And mindfulness in general is very important. Just as I discussed before, where I said that when we have those episodes of automatic picking, it basically means that I'm not in touch with the present moment. Then mindfulness is exactly the tool that I need to be more in touch with the present moment, even if the present moment is not very comfortable or is a moment that I don't really want to be in. Understanding triggers. So oftentimes for automatic picking, triggers can be sedentary activities. It can happen while we watch TV or work on our laptop or are driving. Sometimes it's environmental cues that lead to starting those episodes. And because oftentimes we don't really notice when it happens, anticipating triggers is also really, really important. Um, I might not notice when I watch TV and then subconsciously, my hand wanders to a picking side and I start picking. But after that happened a couple of times to me, after that happened a couple of times, I can prepare for it. I can know, okay, well, now I'm sitting down to watch TV, and then I oftentimes pick automatically. So I'm going to anticipate that and then prepare. For example, by changing my environment, using barriers to bring actions to attention. And that can be a physical barrier, such as using a glove or covering the picking sides, or some of the newer technology that picks up on certain movements when we do them. That can be a lot of different things. And then competing response can be obviously all of the things that we know from competing response, such as using fidgets or sitting on your hands or other types of competing response. But what I also really recommend is in those moments when the automatic picking happens, is to really connect to your senses. Connect to your senses so you return to the present moment out of this kind of absent, sometimes even dissociative state that we're in. With focused picking, awareness level training is really a little less important because usually we're quite aware of the urge, we're quite aware of the fact that we want to pick. Um, Understanding patterns or understanding triggers is less understanding which cues lead to the picking. It's oftentimes what leads to the picking when it's focused are certain thoughts, beliefs, and emotions or stress levels that have built up throughout the day, right? And understanding that can also help to find different solutions to deal with those difficult thoughts or emotions or stress. Anticipating triggers obviously is also very important, but not as much as with the automatic picking, where really anticipating the trigger oftentimes gives us this first step to step in and break the cycle. In terms of changing the environment, barriers obviously can also be very important, but other aspects that I would consider when it comes to focus picking is reducing stress and avoiding clear triggers. For example, the mirror, which oftentimes when we know I have the urge, I want to pick, this is where I'm going to go. And then in finding alternative responses or competing responses, I think emotion regulation skills are really important, as well as all of the other competing responses that we know. I think that is theoretically where I would put emphasis for those two subgroups. But generally, when I work with clients, I try to identify the main triggers that they have, the main situations, um, thoughts, or other triggers that usually cause them to pick, and then I try to create a game plan, for each one of those triggers that involves different elements that I'm going to go through with you shortly, because I deeply believe in this saying or quote, failing to plan is like planning to fail, right? The most important part is to have a game plan in action. And this can look, here is an example of what this can look like. Let's say your trigger for picking, and in this case, it's not even important or not even key to whether it's automatic or focused anymore, right? But um, your trigger is watching TV in the evening, and you want to create a game plan to stop that, the automatic and the focused elements of this trigger. So you think about what are the problems that I anticipate, or the things that will actually make me pick. And that can be everything, as you will soon see. So, for example, one problem, if I want to stop picking my skin while I watch TV, might be a tingling feeling on my skin that really makes me want to pick. And then I find a solution for that problem. Okay, so maybe I have like one of those slightly scratchy sponges in place that I can use that will kind of help me with this feeling, but not damage my skin. Another problem, if we face this trigger of watching TV in the evening, might be it's the evening. It's the end of the day. I have less self-discipline. Sometimes I might even allow myself to pick. What do I do with that? Well, I try to put some reminder in place that reminds me of why it's super important for me to not do that and why I might regret it in the end. So, for example, I don't know if you find this sentence motivating. I find it motivating. It's easier to not start than to stop. Another problem that makes watching TV such a major trigger might be that where my hands rest, right? So maybe they're on my chest if I lie back, or somewhere close to my face if I have like a hand rest, and then the way to some kind of picking side might be very, very short. So in order to tackle that problem, I might put barriers in place, such as wearing gloves or covering rough parts of my skin with pimple patches. And then finally, another problem with this trigger, with this situation of watching TV in the evening, might be that I have a lot of stress built up during the day. And picking would be a very easy solution to kind of relieve some of that stress. So maybe, and that's why planning is so important, because if I'm already sitting down and turning on the TV, not going to do this anymore. But if I anticipate, if I remind myself, I'm really stressed, I had my whole day. If I sit down now, the likelihood of me picking is really high. And I can remind myself, okay, how can I relieve some of that stress before I sit down? Do I want to do a breathing exercise? Do I want to go on a 5-minute walk? Do I need to pet my dog a little bit? Do I need to vent to my partner? Do that and then sit down. So having this game plan in mind or on hand can be really, really helpful. It also includes preparing, obviously. If you come down, come back from work in the evening and you have the game plan, but then you still have to do all the preparation. For example, get the sponge or gloves or pimple patches in place, write the post-it, put it in front of the TV. Your likelihood to fail is higher. So it's easier to prepare in the morning when you're still fresh. So you have everything at hand that you need for your game plan in the evening. And really writing down and preparing for every trigger that way, in my opinion, is a really powerful tool to help yourself cope better with the picking, no matter whether it's focused or automatic. All right. In conclusion, it's really hard to put skin picking in some kind of box, categorize it, or group it with other psychological conditions, because it can be automatic and focused, and those are really two different kinds of picking. Automatic picking might resemble more impulsive disorders such as tic disorders or ADHD, while focused picking reminds more of OCD or body dysmorphic disorder or generalized anxiety disorders. Some brain areas are involved in compulsive as well as impulsive behaviors. Um, even at the same time, but there's differences in activation levels. Automatic and focused picking aren't distinguished subgroups amongst people with skin picking disorder. They usually co-occur even within the same picking episode. You can have automatic and focused picking. Therapeutic approaches may vary slightly between automatic and focused picking, but the basic idea is the same. And the most important part is to plan ahead and have a game plan, an idea of how to cope with different problematic triggers. All right, that's it for today. I want to just remind you of the free resources that we have here at SkinPick, obviously, or webinars, but also online forums and blogs. You are more than welcome to join us on Facebook, Instagram, TikTok, where we're present. And finally, if you do want to sign up for SkinPick, try it out, work with one of our expert therapists, and do habit reversal training within the program, then you can use this promo code webinar100 in order to get a $100 discount for your first subscription. And I'm going to go back to that slide and see if we have any questions. We do. That's great. Okay, so the first one just says OCD, so maybe the person who wrote that wants to elaborate. The second one, can the two kinds of picking occur in the same person? That's what I feel is the case with me. Yes, absolutely. And I love that you asked that question when it came up during the webinar, and then I later on answered it, but it is a really good question. Becky asked, I can't stay on, may I listen later? She's probably gone now, but if you're still here, Becky, you can always catch the recording of every webinar on our YouTube channel, skinpick.com. Even if, but we have a huge library there of webinars that cover all kinds of topics, from basics of like how habit reversal training work, how acceptance and commitment therapy works, to more specific questions. It's a really, really great source of information, in my opinion. When it comes to skin picking, my doctor put me on acetyl L-cysteine. Wait, is that not the same as NAC? Oh, I'm not a doctor. This always confuses me. Wait a second. Let me look that up. Where are you? Acetyl, and it's N-acetylcysteine. So I think, yeah, that's why it confused me. It's written slightly differently, but yeah, that's NAC. Yeah, and I'm not a doctor, but from a recent meta-analysis, which is basically a meta-analysis, means that researchers took a bunch of studies that kind of deal with the same question and try to draw broad conclusions that we can then base on several studies, and then take all of this knowledge and write it in one research paper. I don't know if you can follow me, but a meta-analysis is a very reliable source of information, and NAC, we don't have any real approved medication for skin picking disorder, but based on this meta-analysis, NAC is a very promising candidate. So also it doesn't have a lot of side effects. So I always think it's worth trying that. But just so you know, no matter what medication, the recommendation is always to pair it with therapy. Medication can only enhance the therapy, it cannot replace therapy. Okay, can medication, and I see there's probably more questions on medications. I'm going to try to tell you what I know about them, but I'm a psychologist, not a psychiatrist. Can medications trigger skin picking like Wellbutrin, SNRIs? I am a NP and have a PT with a HX gastric bypass and depression who is on, okay, I don't know what all of those things are except for depression, obviously. ADHD, exploring. Okay, so this is a very medical question, and I'm sorry, I will not say anything about that because that would just not be professional because I don't have the expertise. This is really a question you should discuss with a psychiatrist or a neurologist. And then the end of the question, she's seeing a social worker now, and we have talked to her social worker about doing CBT for skin picking if it's OCD related. Okay, so CBT, cognitive behavioral therapy, that is the only thing I can relate to because that's my field of expertise, therapy. CBT, cognitive behavioral therapy, is evidence-based therapy. There is kind of an, how do you call this? A kind of CBT that we use for skin picking disorder, which is called habit reversal training. And then there's also a variation of CBT that is used for OCD that's called exposure with response prevention. Both of those are very effective. So CBT, if you're considering whether it's skin picking or OCD, then if you're not sure whether it's skin picking or OCD or whether your child maybe has both, in any case, CBT is a very good direction for you. In both cases, OCD and skin picking, it is recommended to do therapy and then add medication if needed, but therapy is the base, right? So CBT is an excellent direction, and I would definitely go for that. And in terms of the medication, I'm so sorry, but like if I would say something about that, that would not be professional at all for me. Then we get a copy of this webinar to share with colleagues. Skin picking is not very common in practice, and this is good material to share regarding DX and TX options. Is that because I'm not American that I don't know what all of those abbreviations mean? Anyways, that is a great compliment. Thank you so much. And you can just share the link of the recording on our YouTube channel, and then your colleagues can watch the webinar there. Do we accept insurance? That is a great question. We at SkinPick, we don't accept insurance. You can inquire with your insurance whether they would cover the program, but just be aware of the fact that sometimes they don't cover the whole cost or that it might raise your rates. We also have a more extended answer to that question in our Q&A section on the SkinPick website. If you do want to check with your insurance, you can write to our customer support, support@skinpick.com, and they can, whatever information or documents your insurance needs, they can provide it for you. One person wrote, thanks so much, appreciated this. Thank you. I always really hope that this helps you guys. Yeah. And that you can take something away from those webinars. For so long, I wanted my skin picking to be impulsive. Maybe it's because I don't want to blame myself for this. Because you think that if it was impulsive, then you don't have control over it, and then you have to blame yourself less. I don't think you need to blame yourself more or less, depending on whether it's impulsive or compulsive. Impulsive and compulsive behaviors are behaviors that are really hard to inhibit or to stop. And in any case, the fact that the behavior or that the condition started developing is based on a lot of different factors. A lot of them are not in your control. Those are experiences you went through, genetics, things you learned in your environment, neurological correlates. So I really don't like talking about, blaming yourself or others for it. This thing happened and came into your life, and it's been there for a certain amount of time. And it really isn't the question who's to blame. It's more the question who's going to take responsibility for learning to cope with it and reducing the damage that it does in your life. And that's you, without any blame, without any shame. It's about responsibility and taking responsibility, even if it's not your fault. But definitely wouldn't make any distinction between impulsive and compulsive in terms of blaming yourself. I have ADHD and OCD and BDD and general BDD and GAD. So ADHD, OCD, body dysmorphic disorder, and generalized anxiety disorder. I take Prozac, ADHD meds, and NAC, and I still skin pick. What other medication can I try? So I think that's exactly the point, that medication cannot solve the problem alone. You always need therapy. And in that case, except for ADHD, which you take ADHD meds, because ADHD is you can ADHD is a little bit different in terms of, like, for ADHD, medication is really the most effective solution. But if it comes to skin picking and all kinds of OCD related disorders, which would be OCD, BDD, and GAD, then medication usually is not enough as the sole solution. You need therapy and medication to enhance the therapy, and you're taking all the right medications, Prozac, ADHD meds, and NAC, right? So I think therapy would be the best addition to that. Best CBT. Much thanks to you for doing this webinars. I am 71 years old and have struggled, especially these last few years. Thank you again for these efforts on behalf of those suffering with dermatillomania. Well, it's amazing that you're joining and that you're trying to find better ways to inform yourself and cope with your dermatillomania. And I'm really happy you feel like this webinar helped you. Another question, is there a connection between skin picking and any other forms of picking, such as hair pulling? Interested to know. Yeah, so skin picking disorder, hair pulling disorder, cheek biting, nail biting, those are all body focused repetitive behaviors, and they're all in the same category. Okay. I'm sorry, we have situation here, and also the time is done, so I have to end this Q&A for now. I hope you have a great rest of your day wherever you are, and I hope to see you for the next webinar.